Hello, everyone. Good evening, and thank you for joining us tonight. It's a bit strange experience for me because I can't see you all out there. So anyway, we have two excellent speakers tonight, Associate Professor Wolfgang Poller and Dr. Talcott. The first speaker is Associate Professor Miriam Wolfgang Poller. Miriam is an Associate Professor of Neurology at the Central Clinical School, University of Sydney. She's a neuro-otologist and Director of Clinical Research at the Balance Clinic. Miriam's clinical work focuses on ictal assessment of acute vestibular syndrome presenting to the emergency department, early diagnosis of vestibular disorder by event monitoring, and treatment of intractable benign positional vertigo. Her translational research focuses on capturing acute vertigo in the front line, that is, at the emergency department and general practice. The topic tonight is management of headache. So please welcome Associate Professor Wolfgang Poller. Thank you.
Hello. I'm just going to turn on my screen. Hello, everyone. It's good to be back. And it does indeed feel very strange not to see you. Edmund, thank you very much for the introduction. And I will shortly share my screen with you. Okay, can you see the screen now?
Yep.
Beautiful, thank you. Okay, so I'm by no means a headache expert, but like any other doctor, I have to see a large number of headaches because it is a ridiculously common problem. And so I was asked to talk to you about headaches and their management. And this slide actually shows you a very useful book by David Buchholz called Heal Your Headache. Most of you will probably read it in a couple of hours and find it extremely useful from the perspective of management. And in fact, I lend it to some of my patients as well. So it's a common reason for seeing the doctor. There's a remarkable number of differential diagnoses, so it's good to have a systematic approach. Now, our systematic approach is provided to us by the Royalty of Headache, the International Headache Classification Society, and these are the people who have really given us, they're the lawgivers, and who tell us how we should look at headache. And I just thought I'd outline the different types of headaches. So the way I see headaches, there are naughty headaches, nice headaches, and cute headaches. So primary headaches, the ones that you and I encounter, generally have a reasonable management plan. These are migraine, tension type headaches. And this group you might not know too much about. It's called the trigeminal autonomic cephalalgias, or TACs. Okay, these are the primary headaches, the treatable ones. Then there are the naughty headaches, which are the ones that could be secondary to a space-occupying lesion, meningitis, substance-related, related to psychiatric illnesses, metabolic disorders. These are the ones that merit further attention, and they can be difficult to treat. And of course, there are the interesting ones like the benign sex headache, the headaches caused by space travel and exercise, and I don't think I'll be spending too much time talking about those. So let's talk about the history. There are some essential questions that you need to ask. First of all, when did the headache first begin? And has it been recently worse? And the reason why it's important to ask this question is because a first headache in someone who's older than the age of 50, a change in the type of headache, or a worsening headache might actually make you want to investigate it further. Headache location is helpful from a diagnostic point of view, specifically because there are two types of headaches that are one-sided, the migraines and the trigeminal autonomic cephalalgias, or the TACs. Okay. What about headache severity? That's an important question from a diagnostic point of view. Tension type headaches are mild to moderate, and often we don't see these in the emergency room. We see them in outpatient clinics. Migraine, on the other hand, is moderate to severe. And those of you who've seen cluster headaches will know that they will say it's the worst human pain ever encountered. Headache quality is very important. Migraine is a pulsating headache. Tension type headache is kind of diffuse and vice-like, like a band across your head. And then the short-lasting headaches, which are, again, this group, the trigeminal autonomic cephalalgias, are stabbing headaches. So next we move on to headache duration. This is also a very, very useful piece of history. Migraines, by definition, last between 4 hours to 3 days. Tension type headaches can last days to weeks to months. So does this type of headache called hemicrania continua, which is a subgroup of the autonomic cephalalgias. They last days as well. Cluster headaches last about minutes to an hour. So it's really important to find out from your patient, how long does that headache last? Headache frequency is variable in migraine. In cluster headache, there could be 2 or 3 headaches happening in the same day. And then in the trigeminal autonomic cephalalgias, or the SUNCT syndromes, you could have headaches happening about 50 to 100 times a day. It's also important to ask, what are the relieving factors and what are the exacerbating factors? You all know that a cough-induced or sneeze-induced headache makes you worry about raised intracranial pressure. Headaches that are brought on by standing up makes you wonder about low pressure, so low CSF pressure headache. Alcohol is a contributor to both migraine and cluster headache, and then there are some headaches that are provoked by sexual activity, so subarachnoid hemorrhages and the benign sex headache. So it's worth asking about exacerbating factors. What are the associated features of a headache? So you know very well that migraine is by definition associated with nausea, photophobia, phonophobia, and even sometimes osmophobia. The trigeminal autonomic cephalalgias have a specific group of associated features like a bloodshot eye, tearing in the eye, a runny nose, sweaty face, and generally swelling around the eyelid. So those are features that would make you think of a trigeminal autonomic cephalalgia. Then there's giant cell arteritis, which is associated with jaw pain, shoulder pain, hip pain, and general proximal muscular pains. When you take your history, it's also important to figure out whether there is evidence of a systemic illness like fever or weight loss. So moving on to other historic factors, these are the kinds of things that I ask my patient, not specifically because they're diagnostically helpful, but because it will help me to manage them better. So I generally ask them about their remaining medical history, psychiatric history, specifically about sleep quality, because I don't want to miss obstructive sleep apnea. And I do ask a great deal about their lifestyle, like how much time do you spend at the screen? How much time do you spend on your telephone? How much water do you drink? Have you recently been on a diet? Do you eat 3 meals a day? You'll be surprised at the answers you get. Do you actually take time to exercise? And what's your medication history? So moving on to the examination, there's a basic screening examination if your time is limited, and I've just limited myself to the essentials here. So fundoscopy and visual fields are important, but obviously if you're seeing the patient by webinar, I would just ask them to occlude each eye. Can you see the room in front of them? And that's the extent of eye exam. Screening cranial nerve exam in a face-to-face interview would involve looking for a Horner's syndrome, doing the pupillary reflexes and looking for a facial droop. But if you're in a webinar situation, it would be more looking for a facial droop and a Horner's syndrome. The screening limb examination, if you see the patient face to face, you will be able to do a quick tone, power and reflexes exam. But if you're only seeing them in a webinar, you might just get them to do an upper limb drift and ask about their gait. Typically, I would palpate the temporal arteries and the greater occipital nerve, but you could ask your patient to just palpate their own temple and ask whether it's tender. At a first consultation, if this is the first time you are seeing the patient with a headache, it is helpful to perform some basic blood tests because these factors can actually contribute to headache. So you wouldn't want to miss a metabolic abnormality like anemia, hypothyroidism, iron deficiency, because all of these will contribute to headache frequency and severity. An ESR, especially in elderly patients, is a must. If your patient is experiencing a new headache, and especially if they're over the age of 50, if they have a background history of a malignancy or if they're immunosuppressed, then you would want to image them. So what would I consider red flags that necessitate imaging? Worsening pattern of headaches, sudden severe headaches, focal signs or an unusual aura, cough or Valsalva-induced headache, and a new or more prolonged one. If it's orthostatic, new headache in cancer or HIV. If there are signs of obstructive sleep apnea, I would consider that a feature of a secondary headache. Any new headache in the elderly, I would be considering giant cell arteritis. So moving on to treatment, you need to first diagnose your headache syndrome. You'd like to offer specific therapy and then lifestyle advice. And when offering lifestyle advice, you would think about sleep, hydration, diet, how much screen exposure they have, do they actually exercise? Is there some secondary factor that they're missing like temporomandibular joint arthritis or neck pain? And when you think about treatment very early in the piece, I think it's important to tell your patient you might not be expecting a cure, you might be expecting a reduced frequency and a reduced severity. So we talked about secondary headache syndromes like neoplasms, malignancies, obstructive sleep apnea. Let's talk about the primary headaches. The most common ones you will encounter are tension type headache and migraine. And then there's the trigeminal autonomic cephalalgias and the other minority of interesting headaches. So let's talk about migraine. Everyone knows migraine. It's an episodic headache. They require 5 episodes lasting 4 hours to 3 days. At least 2 of these factors, it's got to be one-sided, throbbing, moderate to severe, worsens with moderate exercise, got to be associated with at least one of the following: nausea, vomiting, photophobia or phonophobia. So when I manage my migraine patients, if there's one thing I'm allowed to do, it would be to modify their lifestyle. So I do spend a bit of time asking them to try to minimize how much scrolling they do on the telephone, how much time they spend sitting around watching telly. Consider dehydration and hydrate. Consider avoiding junk food. Pay particular attention to their sleep and do whatever is possible to reduce stress, although that might not be as easy as it sounds. So there are two types of therapy that we always consider. There is acute therapy and then there is preventative therapy. So when I give my patients a script, I would give them a nice prescription that is for the easy to manage headache. So that is your Aspro Clear, Voltaren Rapid or Panadol. And some patients will be able to identify the easy headaches and use the nice scripts for that. And I also give them the naughty prescription, which is a triptan. Always start with sumatriptan, 50 milligrams PRN. Other agents that you can try are naratriptan, which is long-acting, or you can try Relpax. The dose is 40 milligrams, or Maxalt wafers, 10 milligrams. So it's good to have a stratified approach. That means that you would give them a prescription for the milder drugs and for the more intense drugs, and give them the advice to start the medication as early as possible. Very soon in the piece, they will learn to identify whether or not their migraine headache is responsive to simple analgesics and Aspro Clear. And if it isn't, it's really worthwhile trialing a triptan. So when would you consider starting a prevention drug? If there are 3 or more moderately severe headache days, even if they don't respond to therapy. So that's pretty nasty if you have more than 3 severe headache days and there's no drug response. That means you've got to move on to a preventative quick smart. What if all your headaches are actually responsive to drugs? Even then, if you're having about 6 to 8 headache days a month, that's got to be pretty intrusive. So that's the time you would again consider a preventative therapy. If there are contraindications to your triptans, for example, heart disease, then you've got to think about a preventative quite early in the piece. If the symptoms are really frightening, so brainstem aura or hemiplegic migraine, that's a time you'd again want to think about a preventative. All things considered, if there's a significant impact on the patient's life, you would want to consider a preventative. And if the patient is at risk of developing excessive medication use and going down the path of a chronic daily headache, it's good to cut your losses and say, right, we are starting a preventative now. So these are some of the preventatives that we commonly use. I always start with a natural product, a combination of magnesium, vitamin B2, feverfew, and coenzyme Q, and there are many brand name products that have these combinations on the market. Sandomigraine or pizotifen is a good old-fashioned migraine preventative. Particularly for the younger people, I would consider Sandomigraine. Dathiapine and amitriptyline are tricyclic antidepressants that are widely used as migraine preventatives. Propranolol is one that is popular, especially in the general practice world, because it's a very innocuous drug. And then there are the lesser used drugs, calcium antagonists, lamotrigine, Topamax, and the least used drug is probably Sibelium, one that we reserve for the difficult migraines. So These are the doses recommended by the American Academy of Neurology. I just want to draw your attention to the starting dose of amitriptyline, only 10 milligrams. Starting dose of Topamax, only 50 milligrams. I actually start with 25 milligrams a day, so that's 12.5 twice a day. Then here are all the natural ingredients that you would start, and magnesium is at 400 to 600 milligrams daily, riboflavin at 400 milligrams daily. So how do we choose these drugs? I'm just going to skip those slides. When you pick a prescription drug, the first thing you've got to tell your patient is that the expectations are really modest. This is not going to work like magic. This has to be given a solid trial. And so if your patient has high blood pressure, you would choose a beta blocker. If they are anxious, you would choose a beta blocker. If they are lean and they have a lot of nausea, pizotifan is a good choice. Tricyclics if they have a pain syndrome. Topamax, which causes a loss of appetite if they are obese. And then lamotrigine and epilim are particularly helpful if there's a mood disturbance. How long is a trial? You would want to trial these for a period of about 2 months on full dose. And if you've had a really good result, you'd want to start tapering at about 6 months, expecting that you've broken the cycle of migraine. Botulinum toxin is considered if there are chronic migraines, that's more than 15 headache days in a month, after 3 or more preventatives have failed, or if your patient is just simply unable to tolerate your oral medications and you've tried a few. There's a lot of excitement around anti-CGRP antibodies, and they are shown to be efficacious for both chronic migraines and episodic migraines. The average improvement is about 4.5 less headache days per month, compared to about 2.8 headache days less for placebo. So you might think that's really modest, but from the patient's perspective, about 5 less headache days is actually a big deal. Now, currently the big problem with these drugs is that they're really expensive. Even the least expensive of them costs $300 a month. So I have to be honest and say, I don't have a single patient who can afford this drug at the moment. So any questions about migraine? So I might move on to tension headache. This is the exact opposite of migraine. It's mild to moderate in intensity. The headache is diffusely localized, vice-like, can last weeks and weeks, and no associated phonophobia, photophobia, or nausea. Much of the management is really in the domain of simple therapies, simple analgesics, trial scalp massage, neck massage, relaxation techniques and biofeedback. I would strongly recommend cognitive behavioral therapy, especially for those of your patients in whom you think that anxiety is playing a big role. The most widely used drugs are tricyclic antidepressants. Starting dose for amitriptyline would be 10 milligrams. Starting dose for dothiapine would be 25 milligrams. Less commonly, you would use an antidepressant like venlafaxine or even mirtazapine. But these simple measures, trialed over a very long period, are really worthwhile. Now, we come to the less common group of headaches, and I felt I had to talk a little bit about them. These are called the trigeminal cephalalgias. These have all one common feature, and that's one-sided red eye, one-sided facial pain, tearing, sweaty face, runny nose. They're all the same group of headaches and a few different ones. There's hemicrania continua, which is the longest lasting headache, lasts several weeks. There's cluster headache, which is the one that you are very familiar with, lasting 15 minutes to about an hour, occurring several times a day. Then there's paroxysmal hemicrania, which lasts a few minutes and occurs 5-10 times a day. And then there are a couple of rare conditions called SUNCT and SUNHA. They're both pretty much the same, short-lasting, unilateral, neuralgiform. I have forgotten the CNT, I think it's short-lasting, unilateral, neuralgiform headaches with conjunctival injection, okay, and autonomic features. So these last seconds, and they can occur about 100 times a day or 50 times a day. So I'm just going to give you a couple of case histories so you will remember. He is a 40-year-old bartender. He says that he gets a sudden severe retroorbital and forehead pain. The pain is worse than childbirth, he says. It happens about twice a day, lasts about 45 minutes, happens at exactly the same time every day, and occurs around springtime every year, lasts for about a month in clusters, and by summer it's gone. One glass of wine sets it off in about a couple of minutes. When he gets the headache, he feels like pacing up and down the White House. Okay. How do we treat this? This is cluster headache. Acute treatment is oxygen, not just 2 liters via nasal prongs. This requires 10 liters of oxygen, heavy duty, heavy flow oxygen via non-rebreather mask for about 10 minutes, and that is highly likely to make the cluster headache abate. Other options are subcutaneous or intranasal triptans, and another new treatment that is available is vagus nerve stimulation. All this falls under the domain of acute treatment. Then there's a group called bridging treatment. This would be oral steroids or injectable steroids, specifically in the distribution of the greater occipital nerve. If your headache cluster is particularly long, you might want to give a short duration preventative, and the most widely used short duration preventative is verapamil. You may want to undertake ECG monitoring at 2 weeks, 4 weeks, and then approximately monthly for a period of about up to 6 months if you're maintaining them on the verapamil. Topamax, lithium, and baclofen are also useful agents. How are we going for time? Because I might stop there and take some questions. Edmund?
Yes. Yes, hello. Yes. So yes, I've got about 3 questions at the moment.
Okay.
The first one is there any benefit to blue light glasses in headaches?
Okay. You know, that's a very interesting question. I learned this from my patients. So anecdotally, there seems to be some benefit, particularly in those patients who are doing in professions like secretarial work, lots of research. To my knowledge, there has been no clinical trial, but anecdotally, I would say I do have a couple of patients who say that they've used blue light filtering glasses and that they have less eye strain.
Okay, that's good. So the next one is, can you suggest a brand for the magnesium, the riboflavin, the preventatives?
Okay, in Australia, there are 2 brands available. There's one called Blackmore's Remedy, spelled R-E-M-E capital D. if you're using this one, you should use 4 tablets a day. We usually try this for about 2 months and then have a sort of a catch up and see how the patient is doing. The second brand name that we use is Bioceuticals Migraine Care, and the tablet is double the dose of the remedy, so we use 2 tablets a day. You've got to warn your patient that with either brand they will have bright yellow urine, and also I would also suggest that in a small number of patients I've experienced that they have a bit of polyuria. A small number of patients will say that they had irritation around the lips, in which case I would just halve the dose.
Do you find how effective do you think those things are in your experience?
Okay, so you know that there is such a thing as a placebo effect, and many patients love taking a natural product. Just to give you an idea, about 50 to 60% of my patients who have migraine would be merely on this one. So I give it a really solid try. Next year, Dr. Talcott and I are hoping to start a proper placebo-controlled clinical trial of this drug, of these agents. So we will have the real answer for you next year. But for the moment, we just know that anecdotally about 50 to 60% of patients appear to be happy with this drug.
Okay, good. So the next question we have, do opioids have a place in treating severe headaches?
I'd like to say no. There are rare instances when you've tried everything else and you rarely use an opioid. One instance where I've kind of had to use it is in pregnant women. So there are only 2 choices in pregnant women, and I would try first paracetamol with Maxolon, paracetamol with Stemetil, and then have to go for codeine phosphate. In your non-pregnant adult patient, my advice is do your best to avoid going there. You could try start off with Asproclear, non-steroidals, go through all the different triptans, and if they fail, would you recommend limited doses of opioids? I think it's really important to move quick smart into a preventative, and if your preventative plus your triptan is not achieving the desired effect, then I think it's important to quickly refer the patient on rather than getting them used to the opioid prescription. Because the problem with the opioids is that you will rapidly transition them into an opioid overuse rebound headache. So chronic daily headache is really hard to dislodge. So I think it is better to quickly move on to a preventative rather than go down the path of opioids. So I don't have any patients in my clinic who go home with an opioid script.
Yeah, that's good. No, I agree there. So the next question actually is from Kriti Kapila. But sorry, I can't really understand the question very well. So I hope you don't mind, but if you can maybe retype it in. I'll go on to the next question. Yes, your talk has been very, very good, and the information, there are lots of very useful information. So one of the questions was, can we have a copy of your slides?
Absolutely, yeah. And in the slides, you'll have some bits of the rarer headaches as well. And yes, of course, yeah, I will pass it on to Bertha.
That's great, thank you. So the next question is, please talk a little bit about sentinel bleed of SAH.
Yeah.
Always about worrying about missing this.
Okay, so yeah, that is difficult, isn't it? So typically, the most common situation in which you would encounter your subarachnoid hemorrhage is actually the sudden severe headache or the sudden headache for the first time during intercourse, and it would be a sudden severe headache, and that would merit investigation for subarachnoid hemorrhage with CT scan, with a lumbar puncture and a CT angiogram. The sentinel headache is the difficult situation where the patient has had a few headaches leading up to them. Okay, and my feeling is that if it is a new headache in a patient who has never experienced a headache before, that would merit investigation with at least a plain CT. If the patient has had a long history of several months of headache or several years of headache, and they are presenting to you because progressively the headache has not responded to the simple measures, then I think you shouldn't worry about the sentinel headache. But if the headache started last week and they have come to you seeking help, I think if their neurological examination is normal and you have performed a plain CT, I would think that is good enough. So this is a situation where the general practitioner is a lot more vulnerable than the neurologist. But I think you can't be worrying about a sentinel headache in every single patient. So I would suggest that if your patient's headache is only weeks old, it is reasonable to 1, do a detailed neurological exam, and 2, do a plain CT. And if you're particularly worried about that this is actually heralding a subarachnoid hemorrhage, the quality of CT angiography is really very good in our day and age. So we are a little bit more fortunate that you can actually do a CT angiogram, and in fact the resolution of a CT angiogram is better than that of an MRI. So if you have concerns, that's what I would recommend. But I think if it is a recent headache that has been present for weeks, you've done your plain CT or detailed neurological exam, that should be adequate.
Good, thank you. So I think we probably have time. Anyway, I'll just try this question first. How much crossover is there between tension, migraine, and the trigeminal type of headaches, please?
Okay. With the trigeminal type, so there's a bit of crossover between tension and migraine. The main reason for this is that migraine patients will say, I have my bad headaches and my ordinary headaches. And you'll find that what they call their ordinary headaches is strikingly like the tension headaches. But here's something to think about. In these people who actually had true migraines, when the tension headaches were treated with triptans and the tension type headaches, they still responded as well as the migraine headaches. So that tells you that the patient who actually has what sounds like a true migraine and separately has what they call ordinary headaches, these are in fact another version of their migraine. So that's one half of the story. With regards to the trigeminal autonomic cephalalgias, these are very distinctive. They will have the burning eye, the tearing eye, the red eye, the sweaty face, the runny nose, and those are actually classic symptoms that make you think about the trigeminal autonomic cephalalgias. And it's really useful to identify them because their treatment is a little bit different from the migraines. And I've actually included a couple of slides later on. It's quite possible that these people will have a little bit of photophobia or phonophobia. But the key thing that helps you to differentiate these syndromes, the trigeminal syndromes, is their duration. So the cluster headaches will last only a few minutes to an hour. And it's really worthwhile trying that oxygen with them. The paroxysmal hemicrania will last only a few seconds, and it will recur about 25 to 100 times in a day. And these people, they will respond to treatment with indomethacin. Then there's another group of really prolonged treatment, prolonged headaches called hemicrania continua, where they have the red eye, the red nose, the red face, and their headaches will continue non-stop, one half of the head, for days and days and days. And these people, I just have got a slide, these people will have, they'll have a response to indomethacin started at 25 milligrams TDS, then going on to 50 milligrams TDS, 75 milligrams TDS. So it's the duration that will help you here, okay? And also that conjunctival injection, the runny nose, the sweatiness. So just a very quick clinical history, frequent types of severe pain, lasting seconds to 20 minutes, red eye 10 times a day, and the treatment is very different. You give them indomethacin, you start a proton pump inhibitor, and this treatment is very, very specific to the paroxysmal hemicrania. So it's really worth looking out for that headache.
Okay, good. So this is the last question. It's actually back to the question from Kriti Kapila. Yeah. So the question is, so patient always have frequent headaches. They always call it migraine, but to us, they probably are tension headaches. Should we treat it like migraine, or should we tell the patient they're tension headaches and treat it a different way?
Okay, so if you go through those International Headache Society criteria and you just quickly ask them, okay, does your headache last more than 4 hours untreated? Is your headache moderate to severe? Is your headache associated with nausea, vomiting, photophobia? And if they're not ticking the boxes, then you've got to sit down and say, listen, this is a tension headache. This is not a migraine, and I'm going to have a different approach. I want you to control your stress. I want you to use some local measures, and let's try a tricyclic antidepressant. In fact, that's a really good approach because you're sitting on the fence, and it will work for both the migraine and the tension headache. But it's good to flag it very early in the piece. And it's actually good to have your little checklist. You just go tick, tick, and I often show it to the patient and say, look, you're sitting on the fence for migraine. This is not exactly a migraine. Let's try some gentler measures.
Thank you. Well, thank you, Miriam. Running out of time, so thank you very much for the excellent talk, and especially thank you for letting us have the slides.
Okay, thank you so much. Good night, everyone. Stay safe. Just going to
our next speaker.
Sharing.
Right, so we actually have over 90 person registered to attend tonight. So Bertha may tell us later how many are actually attending this webinar. So our next speaker is Dr. Candice Talcott. Candice is a senior research fellow and head of neurology program at the George Institute. She's a clinical senior lecturer at the University of Sydney and a conjoint senior lecturer at the University of New South Wales. Candice is a practicing neurologist in Sydney and also in rural outreach locations. Her research interests stroke, health systems, clinical trials, and epidemiology. The topic tonight, obviously, is stroke, management in general practice. So please welcome Dr. Talcott.
Good evening, everyone. Thank you, Edmund, for this nice introduction, and thank you all for joining us tonight. So as Edmund mentioned, I'm going to talk about my favorite topic, which is stroke. So these are the learning objectives for tonight. So recognizing a stroke, discussing the referral pathways. We'll talk a bit about acute stroke management, but very importantly, in primary care, about post-stroke management. So I will talk first about what a stroke is, how common is a stroke, which symptoms are suggestive of a stroke, what to do when I suspect that someone has a stroke, what happens in hospital, and what should happen after discharge. And I will just highlight a new initiative. So let's start with a patient. So this is an 80-year-old woman. She's independent from home. She has a past medical history of ischemic heart disease, atrial fibrillation, and hypertension. And she's on aspirin and perindopril. So she presents with left upper limb weakness. So how do we know if this is a stroke or not? One of the key elements in history is the onset. So if she tells you that this weakness has been going on for a few months, slightly getting worse, that's very unlikely to be a stroke. A stroke happens very suddenly, so it should be a very acute onset. Like the typical story would be, oh, I was having breakfast and suddenly I dropped my fork. So something happening very quickly from one second to another, they have a neurological deficit. Sometimes we just don't know because the patient could have woken up with weakness in her arm. So then the circumstances are important. So she woke up with weakness in her arm, but it was also painful. It was really painful from the neck going down to the arm. So that might suggest a cervical radiculopathy rather than a stroke. Or the shoulder was very painful, which could suggest a shoulder problem. And one thing that I had recently is a patient who came to me as an outpatient with swelling of the arm and complaining of numbness in the fingers. Swelling is not a stroke symptom, so I think this points more to a venous or lymphatic problem. Headache is a tricky one because some patients with a stroke, especially if they have a hemorrhagic stroke, can have a headache. But it's not that common in patients with ischemic stroke, although it doesn't exclude it, of course. And some patients with migraine can have symptoms suggestive of a stroke, like patients with migraine with aura can have some weakness or numbness. So sometimes it's a bit hard to decide what's going on there. Same thing with seizures, like patients with a seizure can have their seizure and then after the seizure be weak, something that we call thought paralysis. So typical symptoms of a stroke are focal weakness or numbness, speech disturbance, whether it's dysarthria or expressive aphasia or difficulty understanding someone's speech, visual loss, so visual loss rather than positive visual signs, like if someone is describing scotoma or zigzags in the visual field, it's a bit unusual. It would more suggest a seizure or migraine. So I've mentioned headache already. Loss of consciousness. For a stroke to cause loss of consciousness, it has to be a stroke in the posterior circulation, which to cause loss of consciousness would be a big stroke with a clot in the basilar artery, for instance, and it would be unlikely for the patient to recover from this. So we have a WHO definition of stroke, which dates back from a few years ago, which tells us that the stroke is a rapidly developing event with focal, usually, clinical signs. And in that definition, they say lasting more than an hour or leading to death. But nowadays, rather than looking at the time, we look at the brain imaging. And a stroke should cause brain ischemia, so a lesion on the follow-up brain scan and MRI. A TIA might be something you would see more often in primary care. So a TIA is a brief episode of neurologic dysfunction, which is not associated with cerebral infarction. So there I come back to the fact that we look at the brain imaging, and in the case of a TIA, there is no ischemic lesion to be found. And TIAs are really a difficult, it's really a difficult diagnosis. The patient comes and says, oh, 2 days ago, my arm was not working very well. It's really hard to know what's going on there. Or sometimes I say, oh, I felt a bit dizzy. Is this a TIA or not? This is sometimes really tricky to decide. But it's important to suspect it because patients with TIA are at high risk of having a stroke. I mean, if we look at data from a few years ago, that risk was as high as 15% at 90 days. More recent publications have actually shown that that risk is now is lower if the patient with a TIA is properly managed. And this risk is about 7.5, and even in some very recent publications from a French group, it was around 5% at 90 days. So I was asked to discuss screening tools, and the most commonly used screening tool is the FAST. FAST, so F for face, check if their mouse has dropped. If they can lift their arm up, this is the A. And if their speech is slow or not, this is the S. And if any of these is positive, the patient should go to emergency. This is a very coarse tool. I mean, this could possibly be used via telehealth, but I think if you have the chance to have the patient in front of you, a good neurological examination would be better than this. This is also used as a triage when the patient arrives in the emergency department. Just a few stroke numbers. In 2019, 14.4 million people had a stroke, 5.5 million died, and about 5 million were left disabled because of a stroke. And in Australia, someone has a stroke every 9 minutes, and this number is projected to increase to 1 every 4 minutes because of the increased life expectancy, and that's by 2050. So there are more than 470,000 stroke survivors in our communities. So if someone presents with symptoms that you think could be a stroke or a TIA, and here I think it's quite important when I say could be, because I think if there is any suspicion, the patient should be considered as having a stroke, and the patient should be sent to the emergency department. An ambulance should be called for this patient to be transported to the emergency department. And Ambulance New South Wales, if they are called for a stroke patient, will transport that patient to a hospital where there is a stroke service. So no time should be wasted, because time is brain. So when the patient arrives in the emergency department, the stroke page is activated to let the whole team who will be involved in stroke management, know that a stroke patient has arrived. And actually, in most hospitals, there is a pre-ambulance notification. So the team is notified that a stroke patient is going to arrive prior to the patient arriving in the emergency department. The patient will be assessed for neurological deficit and contraindication to acute treatment. Blood will be taken and an IV catheter inserted. Often, and that's the way it works at RPA, we have a point of care device to check the INR if the patient is on warfarin. And the priority really when the patients arrive in the emergency department is to transfer that patient as quickly as possible to the imaging department. Ideally, the clinical examination, the history taking should almost be done on the way to the imaging department. We don't want to waste any time. So, in terms of radiological investigation, the first test which will be done in emergency is a brain CT scan. In most large hospitals in New South Wales, we do a multimodal CT scan, which includes a non-contrast CT scan and then a perfusion and a CT angiogram. So on the right-hand side there, you have a plain brain CT scan. The issue with this one is when someone presents with acute symptoms, it's usually normal. This CT scan only becomes abnormal after something like 24 hours after the onset of symptoms. So nowadays we have more fancy techniques, and on the left side of the slide there, you see these beautiful pictures, which are reconstructed pictures using software. Usually it's called a rapid software, or some hospitals also use MyStar. So the advantage of these pictures is they show in color the area where there is decreased blood flow. So what you see in green and red there is on the right side of the brain, an area where there is decreased blood flow. And it tells you even more than that. It tells you that there is decreased blood flow, but in red, that the decreased blood flow has led to cell death. So in red, you have an area that we call the core. This is an area where the brain is already dead. There is nothing we can do there. But the area in green is what we call the penumbra. This is an area which can survive if blood flow is restored to this part of the brain. And I mean, you can see on this picture that if we don't do anything, this is probably going to end up being a very big stroke. And this is a CT angiogram. So this injection of contrast allows us to have a good picture of intracranial vessels. And in this case, it shows you a stop on the right middle cerebral artery, where there is actually a clot. So what are the treatments? So the acute stroke treatment, the first one is intravenous thrombolysis. And the drug used for that is Actilis or Alteplase, recombinant tissue plasminogen activator. And it has been on the market in Australia for the last 20 years, something like that. This drug can be given within 4.5 hours of onset. So highlighting again that stroke is an emergency. It needs to be given quickly. And unfortunately, it cannot be given to everyone. So there are some contraindications. And the main one is patients on anticoagulants, properly anticoagulated. They cannot receive this drug. Another important one, especially for doctors working in hospitals, is patients who just had surgery. They should not receive this drug. So what else do we have? We have what we call thrombectomy or clot retrieval. That's not for everyone. I'll come back to that, but first I'll show you what it's about. So this is an endovascular technique which will allow removal of the clot, whether like it's shown on this picture, a stent is deployed and then the clot is pulled out of the blood vessel, or they can use an aspiration technique, or they can use both stenting and aspiration again to remove the clot. So does this work? So this is for intravenous thrombolysis with RTPA. So you see here 100 patients. In green, you can see patients that are better or completely normal. So about 32 patients will get better or be normal after the treatment. But at the bottom of the picture, you see that about 6 of them will either die or be worse. So the risk of bleeding with this drug is about 6%. And one key thing which this picture doesn't really show you is, again, that time is really important. If we use the measure number needed to treat, if we manage to treat the patient within 1.5 hours after the onset of symptoms, the number needed to treat is 4.5, which means that you have to treat 4.5 patients for 1 patient to return to independence rather than a lifetime of disability. And this number increases significantly. And so if you treat your patient just at the 4.5 hours mark, you have to treat 40 patients for 1 to benefit. And the issue with intravenous thrombolysis is that it doesn't work well for large vessel occlusion. So as you see overall, the likelihood to reopen a blood vessel when using intravenous RTPA is about 30% for these large blood vessels. So what can we do? This is here that comes endovascular thrombectomy. So only patients with large vessel occlusion will be eligible for endovascular thrombectomy. So you basically have to see the clot in one of these large vessels to do the procedure. And the procedure works really well with a number needed to treat of 3, which is low. And also importantly, it can work after 4.5 hours. And the decision there is based on these beautiful CT scan maps that I showed you. And so the doctors involved will decide if there is enough brain to salvage. So if there is a massive penumbra and just a very small area of dead brain, that patient is likely to benefit from this procedure and would likely be a good candidate, even if it's 8 hours since the beginning of symptoms. I mean, it can even be done at 24 hours, but I have to say that at 24 hours, it's less likely to have lots of remaining surviving brain. And in fact, there are just a small number of patients, about 10% of acute stroke patients who are eligible for this procedure. And interestingly, I mean, when this procedure is combined with intravenous thrombolysis, there is no increased risk of bleedings. I mean, the numbers are still around 6%. So we have these two different treatments. The first one is intravenous thrombolysis, and the second one endovascular thrombectomy. And they can both be used in the same patient if the patient has a large vessel occlusion. If the patient doesn't have a large vessel occlusion, the only option is intravenous thrombolysis, but he has to be eligible for this, and often the issue is a time window. Sometimes endovascular thrombectomy can be used alone because there is a clot and the patient is outside of the 4.5-hour time window for the intravenous treatment. Or also endovascular thrombectomy can be used in patients who are on anticoagulants or who just had surgery. And then after these procedures, a patient is admitted to either the intensive care or the stroke unit. And within 24 to 48 hours, we'll start rehabilitation. Usually after 24 hours, we'll be started on antithrombotic drugs, blood pressure lowering, cholesterol lowering medications, and we'll work on risk factor control. So now, after having done all the investigations to try to understand why the patient had a stroke, the patient will be discharged either home or to a nursing home or to a rehab facility, whether the rehab is in the same hospital, whether it's a private rehab, or whether it's rehab in the community. And one of the services around RPA and Concord is a stroke outreach service, which is fully staffed by Allied Health, including physio and ergo, and they will look after the stroke patients after discharge when the patient is at home. The duration of the rehab will really depend on the patient progress. One essential thing after discharge is risk factor management. Quit smoking, regular exercise, weight loss, reduce alcohol intake, good control of blood pressure and diabetes, and if the patient is in atrial fibrillation management. One of the really important ones, I think, is quit smoking. If we look at the numbers, I know it's an old paper, but it tells us that smokers are at 2.5 times higher risk of having a stroke than people who have never smoked. And the way, I mean, one of the key points I think to tell our stroke patients is that this excess risk disappears within 2 to 4 years after smoking cessation. So, in addition to controlling the risk factors, the patient will be given several medications. The key 3 medications are antithrombotic, blood pressure lowering, and cholesterol lowering medications. There are some goals in terms of blood pressure. So a patient who had a stroke should have his blood pressure well controlled and below 140/90. Do we have to reach 130? Probably, especially if the patient is diabetic, but the essential is to be below 140/90. Cholesterol need to be lower, with an LDL goal of less than 1.8. And in terms of antithrombotic drug, if the patient is an antiplatelet, a stroke patient is usually on one antiplatelet medication. It's rare when a stroke patient is on 2 different antiplatelets. The only exception, and it's just for a very short period of time, is when a patient had a TIA or a minor stroke. We tend to give dual antiplatelet for 3 weeks. There might be other cases, but they are rare. Usually we don't like having our stroke patients on dual antiplatelet therapy because it increases the risk of bleeding. This slide shows you the progress trial, and I think it's important because this was the first trial which showed that lowering blood pressure in someone who had a stroke or a TIA was effective at decreasing the risk of recurrence. And they included about 6,000 patients, randomized them into 2 groups, pindogrel plus or minus indapamide versus placebo. Patients, as I said, had had a stroke or a TIA. And they show that by giving this medication and following the patients over 4 years, there was a 28% relative risk reduction of recurrent stroke. And this was associated with a reduction of 9 millimeters of mercury of systolic blood pressure and 4 of diastolic. And this was the same effect whether the patient was hypertensive or not. And that was really the beginning of us prescribing blood pressure lowering medication to all our stroke patients. The story of cholesterol is slightly more complicated. So we know that high cholesterol levels are associated with stroke. This association is not that convincing with triglycerides. Some studies show that yes, it's associated with stroke, some don't. Increased LDL is clearly associated with atherosclerosis. And in terms of treating hypercholesterolemia and expecting an effect on reduction of stroke risk, diet and fibrate just do not work. Statin work. Statin work, and just again, I show you this trial because this is the first one to establish the effect of statin at reducing recurrent stroke in patients with prior stroke and TIA. So the SPARKLE trial, about 4,000 patients randomized to atorvastatin 80 milligrams versus placebo. And in the intervention group, there was a 5-year absolute risk reduction of 2.2% in fatal and non-fatal stroke. So statin clearly works at reducing the risk of recurrent stroke. A few things which I haven't really mentioned so far, but 30% of patients have depression after stroke. So that's something you and I might have to manage when we see these stroke patients. Quite a lot of patients also just feel tired after a stroke, and this can last at least 3 months, but sometimes longer. And there is an ongoing clinical trial looking at the effect of modafinil in fatigue after stroke. One thing I haven't mentioned at all is driving, but just very simply, someone who had a TIA cannot drive for 2 weeks, and someone who had a stroke and has someone who had a stroke cannot drive for 4 weeks and can resume driving if he has fully recovered. And just on this slide, a few useful links, especially the Inform Me website, which is part of the Stroke Foundation, which will show you the Australian stroke guidelines. It's free, free of access. And just the last slide is just to tell you for 2 minutes about a new initiative. So this is a new initiative that I have developed with neurologists, some from RPA, some from outside as well. So one of them is Professor Leo Davies, that some of you might know. So it's a website which allows you to access a neurologist when you are consulting with a patient. So it's really at the beginning of us using this system. We have done some preliminary work with JPAs in a remote area, but we haven't used it much in Sydney yet. So this is really a way to provide instant neurology support. So you have the link there. If you're interested, you can register an account, or I mean, I'm happy to discuss this offline as well. So, and this is my email address. So thank you very much, and I'm happy to take any questions.
Good, thank you. Thank you, Candice. Let's see. The first question: what is a Doppler and EA?
Sorry, you breaking up. I didn't hear you well.
Oh, okay. So the role of carotid Doppler in stroke or TIA.
So yes, that's right. I haven't touched at all about the investigations. I mean, the Carotid Doppler is one of the important investigations that we will do when the patient actually presents with a stroke. And it's to look for any significant stenosis. So the current guidelines recommend, I mean, in someone who had a stroke and has a carotid stenosis on the side of the stroke, which is more than 70%, there is an indication for surgery. And this surgery should be done fairly soon after the stroke, something within about 2 weeks. Sometimes instead of a carotid Doppler, when we do the acute scan, what we do is this part of the CT angiogram that you saw on my slide. We also look at the neck vessels and even the aortic arch. So we do a CT angiogram from the aortic arch to the brain. And that also can give us an idea of any degree of stenosis in the carotid vessels, and gives us a good idea as well of stenosis in the vertebral arteries, which can sometimes be a little hard to evaluate with a carotid duplex or with a neck vessel duplex.
Good, thank you. So the next question, NOAC versus warfarin. It's a selection depending on age or on the renal function.
So first, if someone has a metallic valve, the patient should be on warfarin. There is no indication for NOAC or DOAC, like we give them different names. There is no indication for NOAC there. If the patient has been on warfarin for many, many years, is perfectly well, his INR has been stable, is kind of happy to be on warfarin, probably would leave him on warfarin. But I'm a big fan of NOACs because they are much easier to manage. There is obviously no blood test. There is much less interaction with food and other medications. Depending on the NOACs, the dose might need to be adjusted if the patient has renal failure. If the patient is, or renal impairment, I should say, if the patient is on dabigatran, we probably will give a small dose, or be really careful because the dabigatran is excreted via the kidney. The other thing with some of these medication is also the dose needs to be reduced in elderly. And especially for the dabigatran, it depends on the age and on the patient weight. I'm not sure I've answered the whole questions.
Yes, so yes, the next question. How can we educate patient about the necessity of going to the hospital early rather than waiting to see the GP?
Yeah, that's a very important question, and that's really a key question. I mean, this is what needs to happen. And there are lots of campaigns about stroke, especially at the time of the World Stroke Day, or which is in October. Yeah, I agree. I mean, more needs to be done to make sure that patients know that they have to present to the emergency department or call an ambulance immediately. We try to educate patients who have had a stroke and educate their family, but we're not that good yet at informing the public and making them aware of the stroke signs, and especially with patients with TIAs. I mean, TIA is a big problem. Like, patients feel better after a TIA, so why would they call an ambulance? Why would they even go and see their GPs? It's really tricky.
Yes, thank you. So the next question, CoQ10, does it have any benefit in preventing strokes?
I mean, there is nothing, no strong evidence regarding this. I think maybe some cardiologists might be using it, but we don't usually recommend using it in stroke. I know there is lots of research around it, but no strong finding yet. So I don't usually recommend using it. It's a bit the same story with, I mean, people might have heard of turmeric. I mean, it's a bit the same story. There is nothing really strong there to recommend patients to take it. And the other interesting around that same line is aspirin. Should patients who are older than 65 be on aspirin, even if they have had no events? And I would say probably not. I mean, aspirin is still a slight, I mean, still increases the risk of bleeding slightly. So if someone hasn't had any event, there is no reason to take aspirin or one of these substances.
Good, thank you. So I think we only have time for the last question. How does the ED manage the patient who wakes with a stroke? I think it's less than 4.5 hours.
So
or if it's over.
A patient who wakes up with a stroke and is less than 4.5 hours.
Yeah, if it's less than 4.5 hours, or I presume the question may also ask, you know, if they wake up with a stroke, how do we know, I mean, how does the patient know how long they've had the stroke? And what would the emergency department do?
Okay. So if we know the time of onset, if the patient tells you, I went to bed at midnight and he wakes up at 2 a.m. with stroke symptoms that feel easy, that mean and present to the emergency department, we know. So if we know the time the patient was last well, that will give us an indication of that time window, but sometimes we just don't know. So the patient goes to bed at 8 and then wakes up at 6 in the morning and has stroke symptoms. I mean, these days, we very much look at brain imaging. So we do this CT perfusion and see how much brain is already dead and how much brain there is to save if we restore blood flow. So that's really the way we will decide what to do with this wake-up stroke if we don't know when, I mean, if the onset is unknown or if the onset is more than 4.5 hours.
Okay, thank you. Candice, yeah, thank you very much. I think we're running out of time. Your talk has been very informative. Again, can we have your permission to have your slides?
Absolutely, yeah.
That's good, thank you. Well, thank you everyone for attending. You will receive a evaluation link in your email. Please make sure you complete the evaluation so that you can get the points.